Hello, my name's Ian Bruce. I'm Professor of Rheumatology at the University of Manchester, and I'm at the ACR 2017 in San Diego. I've just come from the plenary session, and one of the studies in the plenary session was from the French group who have done some amazing trials in the world of systemic vasculitis over the last few years. And so the trial they presented today was asking the question, what is the best way to maintain remission in patients with systemic vasculitis? So they have a regime which is their usual standard now, which is giving 2 doses of rituximab, 500 milligrams, 14 days apart, and then a dose of 500 milligrams every 6 months, so it's 6, 12 and 18 months. So patients who had systemic vasculitis and were in remission were randomized to that standard of care or to a tailored regime where the patients were followed every 3 months for return of either their ANCA titer or a rise in their CD19 count. And at baseline they were given a single shot of rituximab 500 milligrams stat. Over a period of follow-up, there was no difference in the relapse-free survival between the 2 groups. The tailored regime actually got less rituximab. They only required 3 infusions over the 2-year period. And yet with that, they had a similar rate of relapses and maintenance of remission. So I think this is a very useful study and needs to be confirmed in a larger cohort. But certainly what it tells us is that it may be worthwhile, rather than giving protocolized maintenance regimes of rituximab, that actually a tailored regime to the patient may well produce as good responses and long-term outcomes. And also that's with less exposure long-term to rituximab. And there are some concerns about very long-term use of rituximab, such as hypogammaglobulinemia, so perhaps this more tailored regime will be more as effective without being and possibly safer in the long term. There's lots more going on here at the ACR, and you can tune into Room now to see other updates of the week's events.